to introduce a speaker from UCSF. And Dr. Sharmila Majumdar, PhD, is the Margaret Hart Stuberg Distinguished Professor in Advanced Imaging and the Vice Chair for Research in the Departments of Radiology, Biomedical Imaging, Bioengineering and Therapeutic Sciences, Orthopedic Surgery at UCSF, Bioengineering at UC Berkeley, and is co-executive director of the Center for Intelligent Imaging. Dr. Majumdar has been recognized with a Distinguished Investigator Award from the Academy of Radiology Research, a gold medal from the ISMRM, and is a fellow of the AIMBE and ISMRM. Dr. Majumdar's research focuses on developing machine and deep learning applications for biomedical imaging, magnetic resonance, and microcomputed tomography, and development of image processing and analysis tools, with a focus on bone disorders like osteoporosis, osteoarthritis, and lower back pain. She earned her degrees, MS, MPhil, and PhD in engineering and applied science from Yale University. Thank you so much. It's really an honor, and I'm happy that the timing works so you can join us. I look forward to your talk.
Can you see my screen? Are you able to see my screen?
Yes, it is a PowerPoint presentation, yes.
Yeah, perfect. And it's not in the presenter mode, it's in the regular mode?
It is not the slideshow, but it's not the presenter.
Now?
Yes, all good. Thank you.
This is perfect. Thank you so much. It is a great honor to be here, and I'm so very glad that Homa invited me to this, because I attended the entire seminar at this point, and it has been a highlight. Everything that you have all mentioned, Vivian mentioned the delays and the long decision-making in hospitals. Others mentioned other issues that people face. I will basically be culminating and identifying the same problems using a very specific example in biomedicine, one of biomedical imaging, essentially. So, okay, doesn't seem to want to move. Okay, so the Center for Intelligent Imaging uses intelligent imaging or artificial intelligence in basically assisted imaging to close the healthcare gap worldwide. Everybody has a lofty vision. That is our vision. And we wanted to cultivate an interdisciplinary and integrative environment for academic and industry investigators to accomplish our goals. You know full well, and you've heard about it today as well, we do need an interdisciplinary team with engineers, computer science, medical doctors, trainees, as well as people. We would really benefit from the people from the financial sector as well. We want to revolutionize medical imaging using innovative AI-driven solutions, obviously address the most challenging unmet clinical needs using imaging, and of course, educate the next generation of leaders in imaging AI, because we are an educational institution at the same time. Our goal is to apply imaging across the entire artificial intelligence, across the entire life cycle of imaging. We start off looking at even mundane tasks such as how do you the patient get to the imaging, and how do they get set up for imaging? We talk about technology development, methods for image acquisition and reconstruction to make safer, better, more quantitative imaging. We want to include methods that integrate multimodal imaging data, images from X-rays, images from MR, and actually use data which is not imaging data, but multi-sensor data, different types of structured and unstructured data, to apply all the machine learning tools to this to answer transformative solutions to real world problems, and of course, educate individuals worldwide. So with that in mind, let me just talk about some of the opportunities for AI in imaging. Where could AI be used in imaging? You already heard a little bit about radiology and where it could be used and AI be used, but realistically within imaging, there are a large number of mundane tasks which we could reduce time for those tasks. Interpretation, we've talked about that a little while ago as well. In one of the talks it was mentioned, is very variable in imaging itself. And some of it is subjective, some of it is basically grades. Much of this could be standardized. quantitative and novel measures, which are really technologically challenging, haven't been implemented in clinic, could be implemented. One could do longitudinal following. And of course, one could make imaging faster. So with these opportunities, let me start giving you a few examples of what gets done. These are X-ray images of the spine. I don't know if you see my cursor, but these various lines actually look at the alignment of the spine and angulations across different planes of imaging. And based on these images, the radiologists are asked to compare are basically asked to diagnose scoliosis. And this is the bane of a radiologist's life. If a radiologist ever stops saying, I don't want to grade another scoliosis film anymore, they complain about it eternally, because they have to look at things like sagittal balance, coronal balance, all the things listed here. They look at implant failure. We actually built a model using some of the data that we have and characterized the curvature of the spines in our entire medical PACS database. But we actually developed models with, between the model and the radiologist. The correlations were of the order of 0.98 for sagittal imbalance, for coronal 0.93. But how do we actually evaluate whether these are valid? If you ask two radiologists to provide the same measurements, the agreement, the kappa agreement is 0.6. So we felt pretty good that we were getting to the point that we were developing tools which were as good as the agreement between two radiologists. The area under the curve for determining whether there was implant failure, when there was hardware in the spine, which you see in the image all the way on the right, you can see that is about 0.89. Our radiologists are very, very excited about this, but I will tell you, deploying this into the clinic, it has not happened yet, because there are lots of issues associated with it in terms of whose risk is it when the AI fails. And as somebody said earlier, people are far more diligent about determining the accuracy of the model rather than the accuracy of a physician. So there are multiple hurdles to jump through before something like this gets deployed. Hip fractures. Hip fractures come into the into the emergency department, can take a while to get read by an expert, and therefore oftentimes the surgery takes a little while to take place. We developed a model for predicting hip fractures from X-rays. You see the X-rays over here on all the far side. You see sort of the saliency map, and you can see that the binary accuracy of the fracture, non-fracture is high. It's 96%. And if you actually decide to say what kind of fracture it is, the model prediction is pretty high. If you look at the attendings have a very similar accuracy. But if you then start looking at the residents, who are primarily the people who actually grade these, the accuracy goes down significantly. But if you give a tool like this, which predicts what the hip fracture is, along with the model-aided resident performance, almost gets to that of the attending. So this, again, is a very important feature. And to give you an example, this has been deployed into our clinical reading room at this point, and it has taken me almost a year and a half or 2 years to get to this point, but our radiologists are very happy with it. But one of the questions that comes up is, what is the model learning? So this was a study that we did with Danny Ushizima and Berkeley and others, where during the COVID time, they wanted to essentially distinguish COVID lungs from pneumonia, for example. So what they did is they took a data set, which was our COVID data set, but they also went into a historical data set of CT images, which had pneumonia, and they trained a model. And if you actually look at the model accuracy right on top of this table is basically 0.93. And they thought, okay, if we actually remove and actually just segment the lungs out and just start looking at just the lung tissue, our accuracy should go up, because then there isn't all the other disturbing things in terms of looking at the model is being trained on and looking at. So after isolating the lungs, they found the accuracy actually went down. And this is what started the whole question. So a study was then done where the lungs were totally eliminated and the model was trained, and the model could still distinguish pneumonia from COVID, which obviously if you look at the map, the image below, the color image, it shows you regions that in the last column, the regions which are highlighted where the model is looking at in the absence of the lung to determine whether it's COVID or pneumonia. What is the model learning? The model is learning the background information in the image, which is different between the CT scanners. CT scanners, MR scanners, all undergo upgrades and transitions over the years. And basically what the model really learned is to distinguish the background and the generation of the CT scanners that were being used. So that's one caveat that I wanted to bring up today and introduce this group to in terms of using AI in biomedical imaging, and that is the generalizability of the models. Now, I wanted to talk a little bit about how AI could actually improve and make things faster and reduce mundane tasks even beyond image interpretation. I'll give you an example. In the clinical workflow for MRI, the patient comes in with the indication, and the first thing is imaging protocols are actually developed. At UCSF, in many of the imaging sections, you have a one FTE MD fellow who actually does this. And then after that, the person goes in and you have gets the protocol is established on the scanner, the person is scanned and the images are read. This particular part of providing the protocol has actually, we've been using AI and basic natural language processing, bag of words, BERT, and other tools to actually extract, given an indication, what kind of protocoling should be done. And essentially using that, we've had about 88% accuracy in developing the protocol. If this could be used and transitioned into the clinic, along with linking this with the medical records, one could actually reduce the work burden of one FTE. I'm transitioning a little bit into applications of AI in imaging and talking about some of the integration of multiple modalities besides imaging. This is work being done in brain tumors, where the aggressiveness of brain tumors brain tumors are segmented out from the images and then linked to basically the biopsy results, the metabolic imaging results, in order to come up with a comprehensive picture of essentially predicting aggressiveness and tumor biology. Looking at pathology and imaging, one can link the biology and the imaging and predict better treatment outcomes in brain tumors. This work is, if you see images of individuals on the slides, it's the credits are going to those individuals for being PIs of that particular project. In prostate cancer, artificial intelligence is being used in many, many applications. There is a particular application of using PSMA. It's a particular imaging isotope, which is being used to identify neuroendocrine tumors in the body. And you get whole body PET images, as you see over here. And there are multiple lesions. There are investigators who are identifying these lesions, segmenting them, and identifying them automatically. So you're basically, that's one application. But again, if you're actually trying to look at images, for example, of prostate cancer, and you build a model which works in one university A, the same model does not work in university B, using a methodology of federated learning where the data remains in the universities and the model gets trained on either the data from that university or partial amounts of shared data. That is the kind of work that is going on in order to make the models much more generalizable. And this is where the interdisciplinary teams and the collaborative effort comes into play. And once again, even in prostate cancer, the mixed supervision of looking at histopathology data along with the imaging data is really improving the classification of prostate cancer. The same could be said of breast cancer. There are deep learning algorithms being developed for mammograms. Many of them have actually been FDA approved and are out there. But what is going on in this entire space is to determine what are the factors that lower the accuracy. And one of the things that's becoming very clear is if there are other pieces of anatomy, jewelry in the field of view, it is totally reducing the ability of the model to predict the presence of breast cancer. We've been looking at MRI images. The idea is very similar: segmentation of the fibroglandular tissue in breast cancer, and then predicting cancer and the risk at the level and the grade of cancer. And I've given you all of these things, but the reality is at the base of all the imaging, there are other images are being acquired. MR images, for those who have been in MR imaging situations themselves, take a while. So one of the ways is to reduce the scan time by eliminating the noise and in the images. And I put this up as faster imaging. This is a project that we've been doing with GE Healthcare. And you can see that by denoising the images, there's been a lot of publicity about this. The images have actually imaging time has been cut down by a factor of 2 in brain and spine, now in knee, and one can actually acquire the images faster. Why this collaboration is important is we have a collaboration with one of the big imaging vendors. This works out in the greater scheme of things because where the decision-making time of both entities is long enough and the dependence on the scanner for the hospital and vice versa for the vendor for the hospital exists, we do have some of these collaborations. Some of these collaborations with smaller entities becomes very tedious, both for the smaller entities as well as for the university. One of the things that we are doing is widespread image segmentation. What does this mean? Given any image, this is a knee going in the right-hand top corner. You can see is that the various tissues of the knee are being highlighted and are being segmented out. We've done segmentation of brain tumors in MR images. This is liver segmentation, different tissues. It's widespread. We've been doing it. And one of the reasons for doing this is basically once you have the tissue segmented in your image, whatever image it is, your MR image, your CT image, your X-ray image, then you can also start training models for normal tissue versus pathological tissues, brain tumors versus other kinds of, different aspects of the brain tumor and so on. So I've talked about all of the cancer and oncology applications, but I cannot leave this space without talking about what my interest is, which is musculoskeletal aging and degeneration. The same aspects of segmentation can be applied to lower back pain. And then once you quantify the biomechanics of the skeleton using some of these images, you can do functional MRI, which are methods for actually looking at the brain and relating the MR findings from the patients with lower back pain to the brain. This has this is a study we are doing right now, brings tremendous potential to understanding pain, especially in the lower back, which is quite difficult to pin down. Sports and sport injuries, we've been doing a lot of work with that using AI for image segmentation of the bone, the cartilage, the muscles, and basically characterizing the whole skeleton. And this is just, again, I relate to the biomechanical models where for various loads, you can look at for various actions like bending down, you can start looking at the biomechanics and the load at each vertebral body. This is again showing you a slide, which again brings about a collaboration now we are doing with another vendor for the MR images. And I show you image segmentations. In purple, you see the femur bone and MR images, and they're segmented at 2 different field strengths, Freemax and VIDA. Why is this important? Because images at different field strengths look completely different. And then, but if you can develop a model that works across both and can identify the tissues, then you have actually got something which is somewhat generalizable. And that's what we are working on. How can we get it to work across all the different kinds of images that you have? But what is our procedure now? When you get and acquire an image, you take that offline, you develop a model, you run a model, you get the output. That's not very conducive to clinical workflow. In order to ensure faster translation, there's a team that's working on taking some of these segmentation models and putting it into the pipeline of the imaging system itself so that the actual segmentation comes out directly, immediately at the time of imaging, and nobody has to do these hundreds of data transfers and so on. Now, what is the caveat here? The caveat here is the accuracy has to be established, because all of these contoured images and analyzed images go into the patient's record, and the patient sees it, and there are liability issues, and we are in the process of addressing this. If you ask me what is the toughest part of developing AI for imaging, it isn't actually developing the model. So after you've developed the model, the translation to clinic has been inordinately slow. This is one example where we've been looking at the knee, for example, where we've had AI. Basically, these are images of the knee at the bottom that you see. These are all the different types of sequences you can get from an MR scanner. And each of these shows different tissues of the knee. The grades are very variable between radiologists. If you look at this graph here, you see the agreement between radiologist 1 and radiologist 2 for a normal category knee, partial lesion in the cartilage, and full lesion in the cartilage. If you look at the DL model, which is all the way to the right, the performance of the deep learning model is almost as good as, in fact, better in some cases than the agreement between two radiologists. We took something similar like this and again looked at basically we produce a report which looks something like this in the top right-hand corner, where green is normal, orange is sort of moderate, and severe is red. And we basically provided this to the radiologists who first read a bunch of 50 cases along with a trainee. And then after a washout period, we provided this report to see whether the agreement between the radiologists and the trainee actually improved, because the trainees typically do not agree as well with the radiologist. And as you can see in this graph, the green is where the trainee, after using this this AI-aided report, the agreement and the performance of the trainee actually improved. So we've seen this in a couple of cases, the hip fracture case, this case. Has this been deployed into the clinic? And the resounding answer is no, because the model is as good as the data, or a radiologist as good as his training. And no two radiologists often agree on what is a moderate lesion or what is a severe lesion. There is often a disagreement. We did this in a spine study. I won't go into the details. These are end plate changes in spine. If you just look at the kappa between reader 1 and reader 2, these are two radiologists who are trained. One is a musculoskeletal and one is a neuroradiologist. The kappa was 0.63. The trainee, which was number 3, had a lower kappa with the radiologist. But after post AI training, the kappa agreement of the trainee went up, but the agreement between the two radiologists remained unchanged. Differences in the subspecialty training are not resolved by AI-aided tools. So we have started doing clearly semi-supervised and self-supervised learning models where we do not take readings from radiologists, but we've taken X-ray images or MR images and tried to predict individuals who will undergo total knee replacement using the images themselves. And we've actually found that when you actually include the images in addition to the demographic factors, the MR images particularly identifies within the people who never had osteoarthritis at the start of the study, individuals who will undergo total knee replacement in 5 years. Where does this bring us? At UCSF, we are merging all of our electronic health records, imaging records, and other data into a de-identified database called Information Commons. It gives us a way of starting to look at things like, there's 2 studies going on, meniscus injury, and who are the patients that undergo surgery, what is their medication, what are their imaging findings, how do the models predict some of these outcomes. And similarly, there's another study going on with lung tissues looking at automated CT imaging. Impact on UCSF Health. We have translated a brain tumor segmentation algorithm which identifies the brain tumor and the various regions within it. And we do provide it for tumor boards. That is being used a little bit. We've started using automated liver segmentation for transplant planning using artificial intelligence. We translate, this is a translation you see running in an AR environment so that we can make these tools available. Are these tools used widely in the clinic? And the answer is no. So the caveats and the future needs for imaging AI, I just want to summarize it. That it really depends what data the model is trained on. It affects the model generalizability between populations, scanners, and more. There's a heterogeneity in the gold standard and radiological grading. There are subspecialty and subtle differences which you may not even be able to remove with AI-aided diagnosis. Some of the things that are really needed are clinical trials. How do we engage continuous learning into this FDA scene of approvals? We need diverse data sets. We actually need outcome studies. Does this make a difference in the clinic ultimately? And we definitely need smoother translation to clinic for validation and usage. And with that, I think I would love to thank you and answer any questions you might have.
Thank you, Sharmila. That was excellent. You answered some of my questions. I was thinking, okay, what is the thing that is needed? What is the toughest part? And in the next slides, you always had the answers. Nishant, do we have any other questions in the audience?
We don't have any further questions. Thank you.
Okay. So thank you so much again. And I really appreciate taking time on your Saturday, especially because you're very, very busy. So thank you so much to all the speakers and attendees for coming.